Hi, I'm Dr. Jeff Lawrence, and I'm an orthopedic surgeon for Gunderson Health here at the Baroque Center for Orthopedic Surgery. The great thing about partial knee replacement is that it tends to be very predictable and reproducible for most patients. Outcome studies show excellent overall satisfaction, and most patients will report that they are considerably better than their preoperative status. However, I do believe that expectations are important. With metal and plastic, it is very hard to make your leg feel like it did when you were 20. 2/3 of patients report that they do still have some discomfort with certain activities and that they have a sense that the knee does not feel quite like their own. Again, I think that we can significantly improve your quality of life, but need for you to understand that you will likely still have some symptoms in your knee that will be less than perfect. The benefit of a partial knee replacement over a total knee replacement for patients that qualify is that it is less invasive and recovery is faster. It tends to feel more like your own knee because you retain the anterior and posterior cruciate ligaments, and range of motion tends to be better. The downside is that since it only replaces 1/3 of the knee, if the other surfaces become arthritic, then at some future date you may need to have it revised to a total knee replacement. The survivorship of a partial knee at 20 years is about 90%. If we find unexpected arthritic involvement of the rest of your knee and still proceeded with a partial knee replacement, you would likely have pain from the other disease surfaces. For this reason, we are always prepared to abort the partial knee and to proceed with a total knee replacement. This happens rarely, but in those circumstances, if we were to still put in the partial, you would likely have pain from the other disease surfaces. The total knee replacement in this scenario would then resolve the pain better. To perform this surgery, we use a spinal anesthesia about 98% of the time, and this numbs your body from the waist down. You will have an IV in your arm, and if you prefer, we can make you as sleepy as you want to be. If you would like, you can stay awake and watch your procedure on a high-definition TV monitor. You can ask me questions, and we can discuss the procedure while I am operating. People that do watch tend to find it quite fascinating, and they feel that this really adds to their understanding and to their surgical experience. About half of our patients stay awake and the other half choose to be asleep. A very small percentage of our patients have a general anesthesia for certain health issues or a significant history of previous spine surgery. We use a computer-navigated and robotic-assisted technology to perform knee replacement surgery. This has been a wonderful advancement that helps us to be more accurate and consistent with your leg alignment and ligament balancing. Computer navigation and robotic-assisted technology give us the ability to make these corrections very consistently and precisely. To begin the procedure, I make a medial incision that extends from here to here. The goal of knee replacement surgery is to replace the damaged bone and cartilage of the knee with an implant system to restore normal and pain-free motion. A deep incision along the inside margin of the kneecap allows us to expose the knee, prepare the bone, and to position the knee implants. To perform a partial knee replacement requires a bone resection to remove the top of the tibia and to reshape the end of the femur for the femoral component. When these components work well together, they can come close to replicating the natural motion of a healthy knee joint. After the incision, we proceed with the rest of the procedure. Successful knee replacement is dependent on many factors, including precise leg alignment and implant fit. First, we attach computer sensors to the upper and lower leg by placing pins into the bone of the femur and tibia, assisting us with real-time information throughout the entire procedure. Much like GPS, these sensors continuously track the leg's motion, communicating wirelessly to the workstation's camera. This allows us to preoperatively evaluate the entire range of motion, guiding it through a series of flexing and rotation motions. Using a pointer that is recognized wirelessly by the camera, we virtually paint the surface of the knee so that the computer learns your bony anatomy and the ligament balance of your knee. The computer automatically calculates implant sizing and alignment based on your anatomy, allowing us to visualize how the implant will fit and function before any bone resections are performed. We can then virtually fine-tune the position of the implants on the computer screen to best fit your anatomy and your ligament balance. The computer shows your current alignment, motion, and stability. We can next manipulate the position of the implants on the computer screen to optimize your ligament balance uniformly throughout the range of motion. This prevents the knee from becoming too tight or too loose at different points along the range. The plan is now sent to the robotic assist device. The robotic device is really a smart burr and will deploy only when it contacts bone that needs to be resected. When in contact with bone that is part of the planned resection, the burr activates and removes bone. We have complete control of every part of the resection and can even make small adjustments to ensure that the result will match the surgical plan. As soon as it is moved out of the planning zone, the burr stops instantaneously. Holes are created for the femoral lugs in the same fashion. The implants can now be implanted. Both components are fixed to the bone with an acrylic cement. The plastic insert acts as the bearing surface and snaps into the tibial component. The new partial knee will now move freely and with symmetry throughout the range of motion. Finally, before the leg tracking sensors are removed and the incision closed, we will once again use the computer system to quantify and confirm the patient's post-operative range of motion. The after results should be consistent with a healthy and normal knee and alignment and ligament balance that have been successfully achieved. The art form of a knee replacement is to balance the ligaments so that the knee feels stable and supportive, yet allows for full extension and maximizes knee flexion. This system allows us to be remarkably consistent with achieving these goals. If you look at these two images, they show x-rays of a partial knee replacement after surgery. The resurfaced moving parts are now metal on plastic instead of bone on bone. All stitches are placed below the skin, and the wound is sealed with medical grade crazy glue. This allows you to shower within a few days. I inject the knee with a long-acting pain medication at the end of the procedure. With the spinal, soft tissue injection, and oral pain medication, we do a very good job controlling your pain, but there's no way that we can completely eliminate the pain. We start with the very strongest pain medication that we can use, and we can then modify the dose or the drug as necessary. We have many options, and we will work very hard to find the medication combination that is right for you. It takes me 45 minutes to an hour to do this operation. We will have you out of bed the day of surgery and up marching in place. Patients typically go home on the day of surgery or the day following surgery, depending on how they progress. Patients that have both knees replaced may need an extra day in the hospital. By the time that you go home, you will be independent enough that you can get in and out of bed by yourself, get to the toilet, and climb stairs. For patients that have difficulty reaching that level of independence, short nursing home stay may be recommended. For patients going home, we recommend that someone be with you around the clock for at least the first week. So now that you are home, the focus will be on physical therapy. Therapy is 2 to 3 times a week, and they will be working on range of motion, strength, and swelling reduction. Driving is not for 2 to 6 weeks. For the right knee, you need to have enough strength that you can slam on the brakes and be safe. For the left knee, as well as the right, you need to be off narcotic pain medication so that you are not driving under the influence. So you will need a ride to physical therapy, usually for the first 4 to 6 weeks, and you will need to make those arrangements ahead of time. We will see you at 2 weeks, 6 weeks, and occasionally 12 weeks after surgery. At the 6-week visit, if you are not progressing with your knee motion to your satisfaction, we would discuss the possibility of a knee manipulation. There is a race between the scar tissue buildup in your knee and you regaining the motion. The thigh muscles need to glide over the end of the femur to allow for adequate motion. If adhesions build up between the femur and the soft tissue, it can impede the progression of your motion. A manipulation is a procedure that involves bringing you into the hospital for a few hours, and we would give you some anesthesia so that we do not cause you pain, and then I gently flex the knee to release the adhesions. It literally takes me about a minute to do, and it's typically not a big deal. For patients that need it, it tends to be a big step forward and does not tend to send you back to where you were right after surgery. This is quite rare after a partial knee replacement. As a result of the incision, there will be numbness on the outside of the knee. This will get better over time, but will always be less sensitive on the outside of the knee compared to the inside. Also, about 50% of replaced knees make a clicking noise. This is totally normal and should not concern you. I find that people may worry about these things if I don't mention it ahead of time. Kneeling can be an issue for some patients. You can safely kneel after 2 or 3 months, but some patients do not like the pressure of the front of their knee against the ground. Using a construction knee pad or a pillow may be helpful, especially early after the surgery. It often gets more comfortable as time goes on. Risks, percentage-wise, are quite low, but if they occur, they can be significant. The risk of infection is 1 to 2% nationally, but our infection rate has ranged from 0 to 0.75% in a given year. We do give antibiotics before and after the procedure. We use spacesuits with a hood so that our hair and skin do not flake off into the surgical field, and we have special airflow that blows air away from the patient and not directly on you. Wound healing can very rarely be a problem. Injury to nerves or blood vessels are very unlikely and are 0.6% and 0.2% respectively. Fracture is also very unlikely. Blood clots can develop in your legs, and if they travel to your lungs, can be serious. We put you on medication to minimize that risk. The medication can be a drug called Coumadin, Lovenox, or an adult aspirin, depending on your medical history and risk profile. The use of spinal anesthesia decreases this risk, as does an inflatable device on your feet that helps to push the blood back up through your veins, and the fact that we get you up and out of bed so quickly. The risk of blood clots without treatment can be as high as 50 to 80%. Even with treatment, the risk can be as high as 15 to 20%. The real risk, though, is that the clots can move and go to your lungs, which can be life-threatening. The risk of this is less than 0.01%. The risk of a bleeding complication from the Coumadin is 1.2%. We use only implants that have performed well. I think that it is reasonable to expect at least 20 years out of this knee, but it may be less than that, particularly depending on your weight and activity. The 20-year survivorship of partial knees is about 90%, meaning that these implants are still in the patient and functioning at 20 years. I don't recommend that you run or jump with the new implants, but can pretty much do anything else that you want. The more stress that you put on the implants, the faster that it will wear out. Most patients do not lose enough blood that it's an issue. We used to have all of our patients donate their own blood before surgery, but they then start with a lower blood count and may be more likely to need blood. For most patients, we can use a drug called tranexamic acid, which significantly reduces blood loss. If you were to lose enough blood that you needed a transfusion, the blood bank is all screened for AIDS and hepatitis. The risk of disease transmission is exceptionally low, but not zero. The risk of AIDS is 1 in 200,000 to 1 in 800,000. The risk of hepatitis B is 1 in 200,000, and the risk of hepatitis C is 1 in 3,000 to 1 in 5,000. Finally, there is a mortality rate of about 0.01%. I have never lost anyone on the operating room table in my career, and we certainly don't expect to start. For this reason, we have a family physician from Viroqua look after your heart and lungs and general health before we proceed with surgery. Other unexpected complications can occur that have not been listed. These are extremely rare and have a likelihood of less than 1%. So, these are the main points that I like to discuss with my patients. I will return in a few minutes to make sure that I answer any questions that you may have. Thank you for listening.